Loralee McMahon is the Immunohistochemistry Supervisor in Surgical Pathology at the University of Rochester Medical Center in Rochester, New York. She's worked as a histotechnologist for about 18 years. Her previous job was the Histology Supervisor at a Dermatopathology Lab in the D.C. area, and previous positions in histology included doing general histology and advanced staining for Alzheimer's disease and orthopedics research. She holds a bachelor's degree in biology and a master's degree in medical management. Loralee is ASCP certified as a histotechnologist and has a New York State license as a medical technologist. During the summer, she teaches a histology techniques course for a medical technician program. She's been a contributory author on articles that have been published most recently in the following journals: the Journal of Histotechnology, Applied Immunohistochemistry and Molecular Morphology, International Journal of Clinical and Experimental Pathology, the American Journal of Clinical Pathology and Human Pathology, and it is a delight to bring Loralee to our podium. You'll enjoy her presentation as we always do. Hey, Loralee.
Hi. Thank you, and welcome to everyone that's here today joining us for this webinar. I hope to give you a little bit of my experience as well as some pointers. Today's topic, we're going to be talking about staining and decalcification, specifically the effect that decal has on the tissues that you get in the laboratory on a daily basis, and any of the downstream testing that may need to be done on these samples. The type of testing that can be done on formalin-fixed, paraffin-embedded samples seems to increase every day. So it's very important as a histotech that we look at the impact that this decal might have on the tissue. And it's not as simple as it used to be 10 to 15 years ago, and it can be a hotly discussed topic within the lab. So our learning objectives for today is just very simply a brief overview of some common decal methods, discussion of some of the downstream effects of decal on tissue and staining, and we'll touch a little bit on validation issues that you may have come across. First of all, what is bone? Besides the sample you get in the lab that no one likes to cut, can be difficult and present a challenge. Bone is a specialized type of connective tissue that is made up of minerals, collagen, and cells in the marrow, and it's frequently the site of metastasis in cancers. You will definitely encounter bone in the histolab quite frequently, and it's very important to be able to process these samples like you would routine tumor samples so that the pathologist can get an adequate section to make a diagnosis. And what is decalcification? Quite simply, it's the process of removing calcium ions from the tissue. This process is what makes the bone soft enough so that you can cut it and obtain a thin section for a pathological diagnosis. And these tissues cannot be sectioned routinely like you would a liver or any other organ in the body without some type of decal. You can cut undecalcified bone, but it requires special processing and a special type of knife, and that processing is usually done in plastics or resins, and it takes quite a length of time. It's not routinely done in the histology lab and probably not the best for turnaround time. Like I mentioned, the main purpose of decal is to allow a histotech to get a thin, nice section for diagnosis. This picture shows you an example of a well-preserved and well-decalcified bone marrow. The staining itself looks good. It's bright and clear and crisp, and you can see nuclear detail, and the hematoxylin looks a nice purple color. There's no rips or tears in the section. Most pathologists would be happy with this kind of section. Bone can arrive to the histology laboratory in several ways. You can get a small bone marrow biopsy or a small biopsy of a bone lesion that they took from a patient, and sometimes you can get larger long bones or femoral heads from a diseased piece of bone that is removed from a patient surgically. Both of these specimens need to be processed for diagnosis, and they do require decalcification. That process is necessary in order to obtain a section so that the pathologist can give a diagnosis to the patient. This is just an example of a specimen received in the lab that contains some cells in marrow and some trabecular bone, and in order to get a good section like this, you need to properly decal the section first. And why is decal important? Why do we care so much about it? Because cancer metastasizes to the bone in 68% of breast, prostate, and lung cancers. So that means that 68% of people with those types of cancers have a good chance of getting a bone mets down the road. And those biopsies will most likely end up in the histology lab. It is up to the pathologist to determine if this cancer is from the previous cancer or if it's a new site of primary cancer. And it's up to the histotech to produce a good section in the lab that allows the pathologist to give this diagnosis. It's also very important for the diagnosis and staging of lymphomas and leukemias. You'll get a lot of bone marrow biopsies into the lab that are for this purpose. Without a good section and other downstream ancillary testing that the pathologist may need, they can't render a good, confident diagnosis. And like I mentioned before, all of these patients with a METS from a previous cancer are going to need to have treatment planning that's based upon the type of cancer that they have and based upon the staining that you might do in the laboratory. For example, metastatic breast cancer. These are photos of a patient that had several bone lesions that were found on CAT scan or CT scan, and they were subsequently biopsied. The patient had a history of breast cancer years before and had undergone mastectomy but shown up at a screening CAT scan with these bone lesions. And they biopsied them and sent them to the lab, and the pathologist decided through the staining and the processing that the histotechs did that these lesions were from the original breast cancer. Now the patient is eligible for a specific treatment plan, and this was based upon the IHC stains that were performed in the lab, and ER in this case confirmed that the bone lesion was a breast primary that was estrogen receptor positive. So the choice of decal really makes a difference in this case. Prostate cancer also accounts for about 90% of metastasis to the bone in men. It's the leading cause of death for these patients. So as you can see, it is very important not only to get a nice H&E stain, but it's also important to get a good section for immunohistochemical staining or IHC staining. This is a prostate-specific antigen IHC or a PSA stain that was done on the bone lesion to confirm that the cancer in the bone was actually from the prostate. So now that you see how important the decal process is, we can talk a little bit about the methods that are commonly used in the histology lab. There's the chemical method of decal. This happens when calcium salts are dissolved and then ionized in a strong acid. Thus, it removes the calcium from the tissue, making it softer so that it can be cut. Nitric acid and hydrochloric acids work quickly to decal, so they work very rapidly at getting the calcium ions out of the tissue. They can damage the morphology of delicate tissues if left too long, and they can also make ancillary testing and staining unsuccessful, especially if this subsequent testing is on DNA or RNA or any in situ hybridization techniques. It can damage the DNA or RNA in the tissue. Strong acids such as nitric acid and hydrochloric acid must be monitored pretty closely when you're doing a decal process so that you don't run the risk of over-decalcifying the tissue. Formic acid is also pretty common as an acid decal, and it's a little more gentle than some of the nitric and hydrochloric acids that are out there. It also means that it'll be a little bit slower, so the results may take a little bit longer to get where you need to be for processing and sectioning. There's also a chelating method of decal. This is where calcium ions will bind to the agent and they're removed from the tissue. And I think the most commonly used one, in my experience, has been EDTA. It's an organic compound. It's very slow at working, but it's very gentle, and it tends to have a lot less damage to the DNA and the RNA in the tissue. So in situ hybridization, cytogenetics, molecular testing, enzyme histochemistry, any DNA, RNA analysis that you need to perform is usually successful on these tissues. And I have found that most histology labs are using these two types of decal, either a chelating or an acid decal or some combination. It depends on the specimens that are being received in the lab and what the end result is. So when deciding which method to choose from, the lab needs to decide what's most important. Is it speed? Is it quality? Is it a balance? It's a balance between the two. So it's ideally you need to find that balance. You need to find a balance between speed and quality. Speed is very important for turnaround times and for sick patients that need diagnosis quickly. It's also important to keep the pathologists out of the lab because if they're waiting for their bone to come out, 2 and 3 days, they're going to start to get impatient. Quality also needs to be there as well so that the pathologist has a decent section to be able to render the diagnosis. Because speed is great, but if you end up with poor quality, you're not helping the patient. So finding this balance can be a challenge in the lab because the fast turnaround times are so important nowadays. All the labs are monitored for their turnaround times, and it is very important that these patients get diagnosed as quickly as possible. Our lab struggles with this. It's not impossible to find a balance between speed and quality, but I think that everyone in the group, the lab, the pathologist, the clinician, need to understand what exactly goes into the process of decalcifying the tissue, cutting the tissue, and then doing any type of ancillary staining. It's not as simple as just dumping the specimen into a decal solution and processing it the next day. It's also important to note that decal methods will vary from lab to lab. There's no one-size-fits-all, and I'm not recommending one over the other. The decal method chosen for the lab should fit the workflow. It should fit the specimens that come into the lab. It should fit the patients that come into the lab. You should also make an attempt to standardize it within the lab because if you're going to be validating any of your decalcified tissues with any of your staining, the closest you can get to standardizing it in the lab is going to make your validation easier and more reproducible. But with any process in the histology laboratory, that's kind of difficult. There's a lot of decal solutions on the market, and they all claim to be the best. There's a lot of brand names out there, but I looked up a lot of the brand names and kind of came up with this group of decal solutions. So there's EDTA solutions out there. There's high percentages of formic acid with a little bit of fixation in there, and there's also hydrochloric acid, and then there's acids that have ion exchange resins in them, and formic acid, and there's also a lot of labs out there that may be using a home brew, maybe something that they discovered from an article in a journal where it worked well and they tried it in the lab and it seems to work well for them. I find that it may be necessary for the lab to have maybe 1 or 2 different types of decal solutions present in the lab to make everyone happy. So with all these decal solutions out there and all these methods, what do you do? Which one do you choose? And it can be very difficult to come up with the right answer. What I would do in this case is ask a pathologist. They're the experts in their field. They know what downstream testing might be needed for different diseases. They talk to the clinicians about the patients, so they know what might be needed in the future for these patients. The pathologists also are pretty good at keeping up on all this new testing that's coming out. It might benefit you also to check out some of this new testing. Get online, look up the instructions for use, see if there's any special requirements for the tissue, such as fixation length or type of decal. We know from some of the predictive markers, ERPR and HER2, that there are some guidelines that are very specific to those. You should also look at the workflow in the lab. Is it more beneficial that the histotech monitors the decal? Maybe the pathologist assistants that are taking the specimens can more easily monitor the decal process. Maybe the pathologist does it if you're in a smaller lab and the pathologist is able to do this for you. What works best and gives you the best results is what you need to go with. Maybe you need different types of decal based upon the specimen or based upon the patient's history. This can create some issues, but it can give everybody what they need. And this is what we do in our lab. We rely a lot on the patient history and a lot on the pathologist assistant to decide which decal solution the specimen is going to go into. So there's some questions you need to ask before placing the tissue into fixative or into decal. And the number one question, I think, is what's the patient's history? Does this patient have a history of cancer? The patient's history is what's going to drive the downstream testing beyond the H&E, beyond that routine stain that you get in the lab. So some things to think about. Treat each sample individually. We're in the age of personalized medicine, so how about treating each sample as personalized? What works for one sample may not work for another. The size of the sample matters. You know that the size matters when you try to fix a specimen. A big sample is not going to fix as well as a small sample. Bigger tissues may take a longer time to decal. The type of specimen matters. Femoral heads and bone marrows may need different protocols. You have a hard, long bone, and then you have a bone marrow which is a little bit softer. And bone marrows are often used for lots of downstream testing, so it matters what type of specimen it is. And the desired speed. This is always an argument in our lab as to why the bone marrows aren't out or why the decal takes so long. It's how fast do you need the results. This is the most difficult part of the process. You want fast results, but you also want good results. And going back to treating each sample individually, look at the patient's history. Does the patient have a history of cancer? So if you were to do a literature search on types of decal and the effects that decal has on specimens, you would probably get a lot of differing opinions. At least when I was preparing this presentation and when our lab was going through our decal struggles, we did a lot of literature searches and we found a lot of different opinions. And I've been in seminars where people would say that they know that their stain works well with acid decal no matter what, and then someone across the room would say, I know that my stain works well and I use EDTA. So I think in hands of different laboratories, you need to test it within your lab. Some of the literature that I found, the most recent one I found was in February of last year that said that there was a marked decrease in Ki67 and P53 IHC staining after 2 hours in an acid decal, and there was some effect on the ER/PR and HER2 staining. And there's been a lot of publications out there about adverse effects that acid decalcification has on RNA and DNA studies, and many manufacturers actually recommend that you don't use their testing on acid decalcified tissue. Obviously, if you've validated it in your lab and you can prove that it works, then you're okay. And I've seen a lot of literature that compares several different decalcification methods with IHC and in situ hybridization and DNA and RNA testing. And it seems to be that EDTA, as we discussed, is the best method for these. It preserves the DNA better than some of the acid methods. The issue that comes into play with EDTA, as we discussed before, that it's a little bit slow, but if your end result is FISH or DNA analysis, it may be your best option. If you were to receive a bone specimen and the patient's history is a suspected METS, what would you do? How would you treat this specimen? I would ask questions, find out what the pathologist or the clinician may want to test later on. This can be the most challenging aspect of it. The pathologist and the clinician want fast, accurate results, but they may not understand just what it takes to get there, and you don't want to rush it. Ewing sarcoma is an example of one of these dual-tested samples where you need CD99 or you need an IHC stain in order to confirm the Ewing sarcoma diagnosis. You also need a molecular test for a rearrangement. So you have to be able to do both. So the decal method is very important. An acid may be okay for the IHC, but not for the molecular test, so you need to consider both testing options in this case. This is a different kind of example of a decal struggle. These are tissue blocks, and the center block has a little tiny bit of decal right in the middle of the block, and this can make it difficult to section, although not impossible, but it can make it difficult to section. And what if it's in the middle of the tumor, which often happens with breast cancers? You will get some calcifications in the middle of your breast cancer sample, and you won't be able to section the sample very well. You also need to consider that this patient is probably going to need ER/PR HER2 and maybe some HER2 FISH. Are there any requirements for that, the type of decal? This particular specimen has already been processed, already been embedded, so your options are limited here. One of the things that we can do is one of the things that this presents us with is under decalcification or no decalcification in this sense. You can't get a section. The section will not adhere to the slide. You're going to lose tissue morphology because of a torn up section. And if you do any type of IHC, most likely the heat retrieval step will just blow the tissue off the slide. So what you can do is try to cut it. You'll end up usually with a shredded mess that is hard, if not impossible, to pick up to get a good section. Attempting to cut it will probably nick your blade and drive most histotechs crazy. Since this tissue has already been processed, your options are to run it back through your xylenes and alcohols and back into decal, and you can decal the specimen from that point, which can take some time. Or you can do what some labs do, and I know our lab does it, which is surface decal. You take the block, you place it in a decal solution for a short period of time to soften the surface so that you can take a section. Does this affect the staining? Maybe. I think if you're careful and only place the block in decal for a short period of time, you're probably okay, but who knows? Testing it or validating it may be worth it if you're suspicious of the results, if you think that the decal has affected the staining. But I would be smart about it as well. You know, don't dump the block in decal and go home for the evening and come back in the next day. You're trying to limit the exposure to decal, especially if you suspect it has an effect on the downstream staining. So over-decalcification can present a problem to the histotech as well. It'll be easy to cut, it'll be nice and soft, but it's too long in decal and you're going to start to lose nuclear detail. You will get swelling of the tissue, especially if the fixation was not complete. If the fixation is not complete and you throw it in decalcification, you may end up with some necrosis in your tissue. Too long, you could lose the glycogen in the tissue and you could end up with no staining at all and even make your H&E look bad. Mostly H&Es are unaffected by the length that they are in decal, as long as it's not too short or too long, and as long as the fixation was complete. Like I said, if the fixation was not complete and you plop the tissue into decal, you could end up with some necrosis. Some labs have counteracted this by using a decal that contains some fixative in it. This will allow for fixation and decalcification to occur simultaneously, and it can help speed up the process. So this picture is over decalcified tissue. You can see that it's kind of a muddy looking H&E. You don't see any real good blues, purples, or pinks like you would on a normal H&E stain. There's no nuclear detail, and generally the stain is just not good. And at this point, I think the tissue is probably lost, and you're going to end up with a pathologist that's not very happy. So just a quick rundown of comparison of the methods. You have EDTA, or acid-based decal, or a combination of both. EDTA is slow and gentle. And acids, when they're used properly, are quick, and they have good morphology, but may affect other testing. So the question to ask is, what testing is needed after decal? Immunohistochemistry, or IHC stains. These stains are the basis for treatment decisions for many types of cancer. If you think about ER, PR, HER2, P16, PD-L1, all of these new markers that come out are often the source of treatment planning for patients. Some published data suggests that decal doesn't affect the IHC, that it can actually enhance the staining, kind of begin the retrieval steps. Others state that it can hinder the staining and that it is most likely antibody dependent. One antibody may be affected by it while others are not. That's why they recommend, you testing it in your own hands. I recommend reading the package inserts on some of these FDA cleared tests. More often than not, these FDA cleared tests do not include a cohort of decalcified samples. So when they got their FDA clearance, they did not use decalcified tissues. They usually recommend that you do not do it on decal tissue or that you perform a validation to prove that it does work with your lab's decal method. This is an example of metastatic lung cancer to the bone. Napsin A is a popular stain, IHC stain, to help support the diagnosis that the bone lesion is a lung primary. This patient might also be eligible for PD-L1 staining. That is very big right now in my lab at least, and I've seen it actually advertised on television. So it's important to consider your decal method. If your decal method is affecting the staining, you could end up giving a false negative or a false positive to a pathologist. Predictive markers like ER, PR, HER2, HER2 FISH, and PD-L1, like I just mentioned, are FDA-cleared kits, and they were not performed on decalcified samples. Manufacturers recommend that you do not perform these tests on decal tissue. But we struggled with this because what if that's your only source of diagnostic material? What do you do? You can't refuse the specimen? I don't think that's an option. What can you do instead to get around this? Our lab has taken to the habit of taking the bone marrow and separating if there's any tissue or blood clot from part of the bone marrow, very gently teasing that off of the bone core and placing that piece in regular routine fixative, and then taking the bone core and putting it through the decal process. So that way you have one sample that gets processed without decal, and more oftentimes than not, that tissue or blood clot that came from that biopsy specimen will contain tumor cells, as you can see from the photo, that the testing can be performed on, and that you won't have to worry about the adverse effects of decal. This could also be the basis for your validation. If you were performing a validation to see if decal affects your staining, you could take a tumor sample and divide it in half, put one in decal and one in routine processing, do the same staining on both samples, and compare your results and see if you get the results. We did this for quite a few biopsies in our lab for HER2, and we found that HER2 FISH worked about 50% of the time, and we went back and looked at how the samples were decaled. And it seemed to be related to the type of decal and the length of time that it was in the decal. So this was another reason to push the histology lab to maybe change their method of decal and push a different way to process these samples. Enzyme histochemistry is done in our lab routinely on bone marrow biopsies for our hematopathology group. Acid decal inhibits esterases and trap staining, but EDTA does not. It seems to work quite well. Our lab uses EDTA on most of the bone marrows now so that we can get an esterase stain for our hematopathologist. The only bad part about this is that it takes a little bit longer, so when a pathologist is standing there asking you for their bone marrow because they need to render a diagnosis quite quickly, you have to come back to them and say, it's an EDTA, it's not quite ready yet, it's going to take a little while. They're usually okay with that if you can give them a decent-looking esterase stain. If the patient sample comes to the lab and it needs in situ hybridization or cytogenetic or molecular studies, most of the testing requires that these tissues are not decaled in any strong acids. Strong acids tend to adversely affect the tissue. It degrades the nucleic acids in the tissue. most package inserts that you will find are going to recommend against putting tissue in decal. This, again, can create an issue if it's the only source of diagnostic material. Sometimes it may be worth going back to a previous sample if you have the luxury of that. If a patient came to the lab prior to getting the bone biopsy, go back and do samples on the original biopsy or the original diagnostic material that was not decalcified. Have a conversation with the clinician. See if that you can obtain another sample that does not have, that has not been decalcified, that may not have bone in it. So validation is a huge problem. You have to do it. It's a CAP requirement, and it's good patient care. You want to prove that what you're doing in the lab works. It works with your tissue, it works with your decal method, and it works on the tissues that you stain. This can be difficult if you get samples from outside institutions and you're not sure what kind of decal they use. How do you do a validation on decalcified tissues? I suggest as simply as possible. Like I mentioned before, using two different decal methods, or using a decal method and a non-decal method on the same tumor. Is there any reporting issues? The CAP and other inspection agencies may have requirements for you to report that tissue was decalcified. And if you perform testing on it and the testing is not approved for decalcified tissue, they want you to report that in the report. I would talk to your inspectors when they come through, use your QA or compliance group, and review all applicable guidelines for reporting. Look at all the sources of inspectors, anybody that comes into your lab that is inspecting you, and ask them. Ask them what to do, how to report it, and what's required, and make sure that you fulfill those requirements. The CAP recommends that you test a sufficient number of tissues to ensure that your IHC assay is reproducible and consistent. Just like they want you to validate all your immunos that are not decalcified, they also want you to validate your immunos that are decalcified. The recommendation states that the medical director can determine the size and the extent of the validation. And it should be done on predictive markers and non-predictive markers. So basically everything that you have in the laboratory. How do you do it? The same way you validate any other procedure. You're going to compare it to the currently validated procedure. So if you have a marker that's validated on non-decalcified tissue, stain some tissues that are similar that have been decalcified. See if your results match. You could take the same sample, like I said before, divide it in half, process one with decal and process the other without, stain for the same marker, and then compare the results. You could get another lab to help you. If you have a partner lab out there that is willing to help you, you guys could change tissues, you could do decal, you could stain some of their decaled specimens, you could have your tissues sent there, they could stain them. Compare your rates and see if you can get a 90% concordance rate. And I recommend if you come across an antibody that does not work, if you can't get a 90% concordance rate, that you don't offer it on decalcified samples. I think it's better to not do the testing than to give out incorrect results. The CAP checklist also has a requirement that a disclaimer be present on reports for HER2 testing, and it mentions HER2 specifically, but I think it's probably good practice to report it on any tissue that has been decalcified and then done stains on. It says that you need to put this in there as a disclaimer saying that you did this test on a decalcified tissue and it has not been validated. You should also check with any other inspection agencies that come into the lab that may be applicable to you. I'm in New York, so we have the New York State Department of Health comes in to inspect us, and if you are a Joint Commission, they may have some other recommendations or requirements that you need to follow. So just in summary, bone is the site of mets for many cancers, so you are frequently going to see these biopsies in your lab. And decalcification is necessary for quality sections and proper diagnosis. The type of decal that you use should work for the lab, work for the workflow of the lab, and it should also benefit the patient. You have to be able to give a good result, a confident result that you know what your tissues and your staining is working properly. And as always, the test should be validated prior to use for patient diagnosis. It's a requirement from the inspection agencies, and it's also good patient care. And that's all I have for today. If there's any questions.
Why, thank you very much, Loralee. Great presentation as always, and we do have a number of questions, so let's go right to it. I am wondering if there's any impact on IHC staining if non-decalcified tissue blocks are soaked in 10% formic as a surface decal after rough trimming, but before sectioning.
So I talked a little bit about that, where you often get a breast sample that is been processed. It has a little bit of calcium in it that you didn't see, the pathologist assistant did not see when they were grossing it, but you're cutting into it and you find, oh no, there's this piece of calcium in here, and it makes it very difficult to section. So you take your sample and you put it in formic acid. I tend to think that a short time in formic acid to get a section is not going to affect the IHC staining. I can't say for certain that it's not going to affect the IHC staining, but I think if you can avoid it, you probably should, but I know that our lab does it, and I have not seen, or it's not been brought to my attention that they think that this is affecting any of the staining, especially since it's usually a short period of time, 5–10 minutes, and you're cutting and able to cut a few sections.
Excellent, thank you. How long do you suggest leaving the block in decal for a surface decal, and how long do you rinse it in water?
I would leave it probably, 5–8 minutes and then try, and then if you need to go a little bit longer, you can go a little bit longer, and definitely give it a good rinse, a good 5 minutes in running water, and see if that works for you.
Okay, thank you. All right, now this, there's some comments and questions in here and requests for product recommendations, which we don't do during a CE presentation. So let me see if I can present this to you in a way that you can answer and comment on. In our research lab, we are performing ISH for viral RNA in whole guinea pig ear and whole primate ear bone sections. And I'll soon be doing the same for primate nasal bone and turbinates also. We're using EDTA, and then she mentions a product. It does indeed take longer to decalcify, but we notice the salt or sediment is rubbing the epithelium of some of the specimens. Is there a recommendation to reduce this from happening? And she asked for products, of course, that you can recommend, but maybe we can do that offline. But is there any recommendation that you have to reduce this from happening?
I would say, when I was working in orthopedics research, we would do a lot of mouse and rat and rabbit tissues and like whole bones and stuff, so we would decal for a long time in EDTA, and we would change it frequently. So I think that if you change the EDTA out frequently, you're going to reduce the amount of sediment that's in that solution so that you won't experience that.
Okay. And comment from you, if you would. Immunocal works well for IHC, but we don't see staining with ISH for RNA in the same specimens. Any comments?
Yeah, I have to look and see, but I think that's an acid decal, so you're probably going to run into some issues with that type of decal because it's an acid-based decal when you start doing ISH and any type of DNA or RNA analysis. that's been my experience as well.
Okay, good, thank you. And the questions are coming in fast and furious now, so I don't have much of an opportunity to edit. So let's see how we do here. Can you recommend a book that will cover all the aspects of IHC techniques?
General IHC techniques, I would say probably a good place to start would be the histology book by the self-instructional text by Frida Carson that has some good IHC in there. And also, without being vendor-specific, some of the vendors out there that are big players in the IHC world will give you some educational materials that talk a lot about IHC. There's some pretty good ones out there.
Excellent, thank you. For a typical 2 centimeter by 2 centimeter bone, how long would it take to decalcify in EDTA?
You know, I'd have to check with the Histo Lab because they do a lot of this for me. I know that we used to do the acid decal on these bone marrows, and it took a few hours. I believe that they're now currently, with the EDTA, they're leaving them overnight. But those biopsies are not put into EDTA until the evening hours. So it's not like a 24-hour period, but it may be closer to 8 to 12 hours. I hope that helps. I can probably get more detail if you need it.
Okay, great, thanks. And what about times on surface floating for blocks in decal solution?
I would say, 5-8 minutes and give it a try, and then soak it a little bit more if it doesn't work, but I would try not to go much longer than that.
Okay, thank you. What about rapid decal solutions that stop decal automatically? Is it okay to leave the specimen in the decal solution past the point where decal has stopped? Are there adverse effects of this?
Well, I would say that I don't know. I don't know much about decals. I mean, I imagine that the decal solution would eventually become saturated with the calcium ion so that no more decalcification would take place. But I don't know how you would know what that point is, by the size of the specimen. I don't know if the particular manufacturer gives you recommendations. If the decal has stopped, I don't think there would be any adverse effects to the tissue if you left it in there a little longer. But again, I don't know how you would tell if there's like an indicator that would let you know that the decal process has gone to completion.
Excellent. With the acid type decalcifiers, how long would a piece of tissue need to be in solution before? Well, okay, let's go on with this. How long would with the acid type decalcifiers, how long would a piece of tissue need to be in solution before adverse effects start to show on the H&E and IHC?
With acid decal, I think H&E would take a while. I think it would take a long time for that to happen. Normally, acid decal, you kind of put it in, then you check you check after 2 hours, then you check it. Obviously, this depends on which acid decal you're using. If it's a strong hydrochloric acid or if it's formic acid, they may be a little different. But if you have a strong acid, you want to check it after 2 hours and then check it again after 2 hours. I would imagine that if you left a sample in a strong acid overnight, you might experience some adverse effects to your IHC. And definitely going to see something if you're doing any in situ hybridization. You may not get any results at all.
Okay, great, thank you. And I'm afraid, Carrie Ann, we can't evaluate products here, so I'm going to have to jump over that question. Should validation be done for every antibody that the lab uses? There can be some difficulty acquiring specific cases, tissue, etc. for every antibody.
Well, we struggle with this one as well because we have a large menu, so it would probably take me a long time to get through all the required antibodies and the required decals. So my advice to you is to look at the types of biopsies that you get. Do you get a lot of lung biopsies? Do you get that maybe have cartilage or not cartilage, but bone in them? Or do you get a lot of bone mets that come from prostate cases or breast cases? So your menu of antibodies can be greatly reduced if you're only staining those tissues with the most commonly used antibodies. So like I said in the presentation, bone and prostate cancers and lung cancers often metastasize to the bone. It's a big part of the metastasis to the bone. So you would want to make sure that your antibodies for P63 or napsin or PSA or ERPR, HER2, the ones that you use on those breast, prostate, and lung cancers work in the bone. So you don't necessarily have to do your entire menu, but maybe a subset of it to be specific as to what you get. If you are in a dermpath lab, you may never see a decal specimen or very few decal specimens. So it all depends on what your case mix is.
Okay, good, thank you. The questions continue to roll in. How long should fixation occur prior to decalcification, tissue-specific or general time?
Well, if you have a breast core, you need to follow the guidelines, the ASCO-CAP guidelines of, 8 hours minimum, 6 to 8 hours minimum. I would say that I would follow your routine guidelines for your tissues in the lab for fixation, and then after that time has been achieved, then put them in decal. Our lab does add a little bit of fixation to their EDTA decal. So we decal for a certain period of time, and then we plop that bone marrow into our EDTA fixative. It has fixative in it. We have a home brew, and it kind of helps complete the fixation and then start the decal process.
All righty, thank you. When using EDTA for larger bone specimens over extended time, even when changing the solution frequently, do you keep it on a rocker or stir plate? Also, do you use it at room temperature or heated?
We used to keep it on a stir plate, so we would have a little piece of plastic, something that fit into the container that would elevate the specimen off the surface of the container, and then we'd put a stir bar in there, and we would stir that EDTA while it was decaling and change it out daily. At room temperature, we did at that point in my career had a microwave processor, so we could microwave decal. Again, this was a research lab, so we kind of played with a lot of different things. We did take those bones that we thought maybe were close to being decalcified, and we'd stick them in the microwave and kind of elevate the temperature a little bit to help the decal process kind of go to completion. But I don't think you would have to do the entire decal process at an elevated temperature.
Okay. Do you recommend fixing bone after decaling it? We fix our bone in 10% NBF, then decalcify in formic acid. I don't think you would need to if you've fixed your bone for a length of time and then you've done your decal. I think putting it back into fixative is not necessary. Okay. Can you discuss common tests or methods for determination of decalcification endpoints?
This is also a constant topic in our laboratory. You know, I think that the best and most reliable way is to get in there and feel the specimen, kind of bend it, make sure that it's pliable. You can take a pointer and gently poke it to make sure that you can get into the sample a little bit, although you want to be very gentle by doing this. You don't want to, risk breaking the specimen or destroying any part of the specimen. You can also x-ray the sample if you have access to that. We have in our laboratory as you saw those blocks that I had x-rayed, we have a small x-ray machine that's for the tissue samples that come into the lab. So we can actually x-ray the sample to see if all the bone has gone, or all the calcium has gone from the bone. So I guess, and they don't, by any stretch, x-ray every biopsy that comes through. They basically just go in, feel it, make sure that it's pliable, and maybe poke it with a pointer.
Okay, great, thanks. Next, our lab uses 3 different decals. Do we have to validate all of them?
The hard answer is yes. I would say you would have to, but look at why you use the 3 different decals. There has to be a reason. So if you use 3 different decals, there has to be an endpoint that you're looking for. And why would you use 3 different decals? Are you doing in situ hybridization on these tissues? And I would say, again, like I said before for a previous question, don't stain your whole menu. Just stain those tests that you frequently see are done on bone. And if you're only doing a handful of antibodies on your acid decaled samples, then I think you could greatly reduce the size and the scope of the validation and still cover your bases.
Okay, great, thanks. We get tissue from labs all over the place. How do you handle this?
Well, we get tissues from labs all over the place, and we also send some tissues out for some testing that we don't do here. So I've got tissues from some labs where I wasn't sure of the decal, so I would call and I would ask, and if they wanted her to fish on these samples, I'd say, what kind of decal did you use? And if they told me they used an acid decal, usually what I do is I say, okay, I'll give it a try, but I'm not going to promise that it's going to work. I think that it's dependent on how long they leave it in decal. So, and we struggle with this because we get tissues from all over the place. We, on our test menu that we hand out to clients, we say, please, if you're going to be doing any DNA, RNA, in situ hybridization, to not decalcify the tissue, or, at least discuss it with the pathologist prior to this. And I've sent samples out where they've refused the tissue because they said it was decalcified and that wasn't part of their testing validation. So I think it's a struggle. I think that the more people know about decal, especially the clinicians and the pathologists, that it will help understanding it, but you can't ignore the fact that a lot of cancers metastasize to the bone. And if these patients' biopsies, if that's all they have is this biopsy from the bone, it's very important that we get the testing done right. So it's very important to know what kind of decal it was placed in, and like I said, give it a try. If it doesn't work, it doesn't work, but at least you gave it a try.
Okay, great. And last question. If I use acid for decalcification, how much will it affect the immunoreactivity?
See, I missed the beginning of that question. If you use the...
If I use acid for decalcification, how much will it affect the immunoreactivity?
I don't know. I think it's antibody dependent. I've done some literature researches, and I've done a lot of stains on decalcified bone, and I've seen that the IHC usually works if the decal is within reason. I've done immunos on EDTA decal mouse bone that's been in EDTA for 2 weeks, and it's worked. But I've also done some antibodies that did not work so well on those, so I don't know if it's the antibody or the decal. So I would say that those are the types of antibodies you need to test if you're unsure that it works. If you're lucky to be able to get a piece of tonsil and you can cut it in half and throw half in decal for 3 days and see if it still stains for Ki-67 after 3 days, I think that would be some way to kind of monitor it and maybe guide you in assisting as to how long, at what point is the immunoreactivity going to be gone. you know, take a piece of tonsil, throw it in decal, take it out, take a piece out, process it, you know, keep going. Go for a week, go for a month, see what you can get. There's a lot of different opinions out there if you do a literature search and look at the journal articles.
Excellent. Thank you very, very much. You know, we do have one more question, if you're okay with that. Let's just do one more because you are such a wealth of information. You really are. And I will share all of these really very complimentary comments in the chat box that I've received, so thank you all for doing that. Last question, when trimming down large bones, we have used everything from hammer and chisel, electric striker saws, table saws and band saws, and even handheld saws. Do you know of an anchoring device which helps to hold the bone in place for handheld striker saws?
I don't know
in preparation for decal.
Right. I don't know what these are called, but I know I've seen them in garages, and maybe some mechanics out there know. It's like a vise that you attach to a table, or if you had a workbench, you would attach this to a table, and they actually put the bone in there and to hold it in place, because we struggle with this also. We have handheld saws. We have, disgustingly, an old meat saw that you would get from like a deli. We have, you know, one that you get from one of your local home improvement stores, and we've had some people get injured on these because they don't use the proper protective equipment, so it is a struggle. But I think the thing that has worked the best is using that vise, that they can actually put the bone in there and hold it and then be able to trim like a femoral head and be able to get a good, nice section. You can also, we've done things such as decaled very large pieces in a large amount of decal. Unfortunately, those were done in an acid decal, so they were just looking for primary diagnosis, and that we didn't do any subsequent protein or DNA analysis on the patient, but we have done that and stained very large pieces and put them in huge vats of acid decal, and it's worked quite well. But I think if you look into that vise type thing, I think you'll be surprised. It's pretty good.
And in fact, thank you for what a great community this is. We have two comments. I think it's called an angle clamp. Thank you for Jennifer for that. And Lila says vice grips with gauze on each side works great.
Yeah.
So yeah, I mean vice grips. Yeah, that's a very good idea. It's smaller as long as you can anchor the vice grips to the surface too. Okay, so we are now literally out of time. So I'd like to thank everyone for some great questions and great questions and responses, rather, and a great presentation from you, Loralee. Thank you so much. Just let me remind everyone that if you would like to contribute to Pathology Leaders with an article or webinar presentation, contact Eric Heilman at Leica Biosystems. Susanna has put his email address into the chat box, and if you'd like to access today's recording, you can do that here. Susanna has just put that into the chat box as well. Thank you, Suze. So you can copy and paste that. And if you'd like to receive CE credit or Florida Laboratory credit for a PACE credit, or Florida Laboratory credit, I should say, or certificate of attendance for today's session, here's how that works. When you leave the session, close the WebEx window, and you will see the evaluation open in your browser. So you'll have to close your WebEx window, trust that your browser will have the evaluation appear in a separate tab, fill it out, send it right in. And if you're joining us as a group, whoever has logged in today will be receiving an email from messenger@webex.com. Forward that email to everyone who joined with you in your group, because it will contain the link to the evaluation that will allow them to access evaluation for CE for themselves as well. And if you are joining us from a mobile device, keep an eye out also for that email from Messenger@Webex for the link to the evaluation. Your certificates will be sent within a couple of days if we receive your evaluations in 24 hours. If it takes longer to get them into us, it'll take 2 weeks to receive your certificates. So do send them right in. If you have any further questions from today's presentation, please send them to Eric Heilman at Leica Biosystems. Again, Susanna has put his email into the chat box if you'd like to copy and paste that. So a big thank you to you, Loralee, for an absolutely wonderful presentation. Thank you, thank you.
Thank you.
And a big thanks to Leica Biosystems for sponsoring the Pathology Leaders webinar series. It's a great webinar series, and you should visit pathologyleaders.com/webinars if you would like to see any of the archived sessions as well. And a big thanks to all of you for joining us today. We hope you'll join us again for another one of these Pathology Leaders webinars in the very near future. So in the meantime, have a wonderful and safe rest of your day. And thank you again, Loralee, for a wonderful presentation. Always great working with you. Bye-bye all.